Why BPD is often misdiagnosed. Hi everyone, and welcome back to our channel. We're grateful to have you here with us for another video. If you find this content helpful, please tap the like button and consider subscribing. Your support means a lot and helps us reach more people. Borderline personality disorder is one of the most misunderstood and frequently misdiagnosed mental health conditions in clinical practice today. The statistics are staggering. Studies show that it takes an average of 10 years for someone with BPD to receive an accurate diagnosis. During this time, they often collect multiple incorrect diagnoses, receive inappropriate treatments, and endure unnecessary suffering. The complexity of BPD symptoms creates a perfect storm for diagnostic confusion. Unlike conditions with clear biological markers, BPD diagnosis relies entirely on observable behaviors and reported experiences. The 9 criteria outlined in the DSM-5 can overlap significantly with other mental health conditions, creating a diagnostic maze that even experienced clinicians struggle to navigate. Consider the core symptom of emotional dysregulation. A person with BPD might experience intense mood swings that last hours or days. These episodes can look remarkably similar to bipolar disorder, leading many clinicians to immediately reach for mood stabilizers and lithium. However, the key difference lies in the triggers and duration. BPD mood swings are typically triggered by interpersonal events and resolve much faster than true manic or depressive episodes. The fear of abandonment that characterizes BPD often presents as anxiety symptoms. Individuals might experience panic attacks when they perceive rejection, leading to diagnoses of generalized anxiety disorder or panic disorder. While these anxiety symptoms are real and distressing, treating them as standalone conditions without addressing the underlying personality structure rarely provides lasting relief. Depression is perhaps the most common misdiagnosis given to individuals with BPD. The chronic feelings of emptiness, hopelessness, and suicidal ideation certainly resemble major depressive disorder. However, depression in BPD has distinct characteristics. It often fluctuates more rapidly, is more reactive to environmental factors, and is deeply intertwined with identity disturbance and interpersonal difficulties. The identity disturbance component of BPD creates another layer of diagnostic complexity. Young adults naturally go through periods of identity exploration, but in BPD, this instability is more severe and persistent. Clinicians might mistake this for normal developmental struggles or attribute it to external stressors, missing the deeper personality disorder. Impulsivity in BPD manifests in numerous ways that can lead to specific disorder diagnoses. Self-harm behaviors might be labeled as non-suicidal self-injury disorder. Substance abuse patterns could result in addiction diagnoses. Eating disorder behaviors might lead to bulimia or anorexia diagnoses. Shopping sprees or sexual promiscuity might be seen as impulse control disorders. While these behaviors are indeed present, they're symptoms of the larger BPD picture rather than separate conditions. The interpersonal difficulties in BPD are particularly challenging to assess accurately. The intense, unstable relationships characteristic of the disorder can be misinterpreted as social anxiety, attachment disorders, or even autism spectrum conditions. The black and white thinking patterns, where people are either idealized or devalued, create relationship chaos that clinicians might attribute to communication skills deficits rather than personality pathology. Gender bias plays a significant role in BPD misdiagnosis. The disorder is diagnosed approximately 3 times more often in women than men, but this statistic likely reflects diagnostic bias rather than true prevalence differences. Women presenting with emotional volatility are more likely to be labeled with BPD, while men with similar symptoms might receive diagnoses of antisocial personality disorder, intermittent explosive disorder, or substance abuse disorders. Cultural factors further complicate accurate diagnosis. What appears as emotional dysregulation in one culture might be considered normal expressiveness in another. Clinicians from different cultural backgrounds might misinterpret symptoms based on their own cultural lens, leading to either overdiagnosis or underdiagnosis of BPD. The age factor creates additional diagnostic challenges. BPD symptoms typically emerge in late adolescence or early adulthood, a time when identity formation and emotional regulation are naturally in flux. Many clinicians hesitate to diagnose personality disorders in young people, preferring to wait and see if symptoms resolve naturally. This cautious approach, while well-intentioned, can delay appropriate treatment for years. Trauma history, which is present in approximately 70% of individuals with BPD, often overshadows the personality disorder diagnosis. Clinicians might focus exclusively on treating PTSD, assuming that addressing the trauma will resolve all symptoms. While trauma treatment is crucial, it often needs to be integrated with personality disorder treatment for optimal outcomes. The stigma surrounding personality disorders creates another barrier to accurate diagnosis. Many clinicians feel uncomfortable diagnosing BPD due to the historical perception that personality disorders are untreatable. This reluctance leads to diagnoses of conditions that seem more treatable or less stigmatizing, even when BPD better explains the symptom pattern. Training inadequacies contribute significantly to misdiagnosis rates. Many mental health professionals receive minimal training in personality disorders during their education. The complexity of BPD assessment requires specialized knowledge that isn't always provided in general mental health training programs. This knowledge gap results in surface-level assessments that miss the deeper personality structure. The episodic nature of BPD symptoms complicates assessment. Individuals might present very differently depending on their current emotional state, recent interpersonal experiences, and level of stress. A person might appear stable and functioning well during one appointment, but be in crisis mode during the next. This variability can confuse clinicians and lead to diagnoses that only capture part of the clinical picture. Comorbidity adds another layer of complexity. Most individuals with BPD have additional mental health conditions, such as depression, anxiety disorders, eating disorders, or substance abuse. These comorbid conditions often present more prominently than the underlying personality disorder, leading clinicians to focus on treating the more obvious symptoms while missing the BPD foundation. The tendency for individuals with BPD to present differently to different people extends to their interactions with mental health professionals. They might idealize one therapist while devaluing another, providing inconsistent history and symptom reports. This splitting behavior can result in different clinicians reaching different diagnostic conclusions about the same individual. Insurance and healthcare system pressures influence diagnostic decisions. Some clinicians choose diagnoses based on what insurance will cover rather than what most accurately describes the condition. Personality disorder treatment often requires longer-term therapy that insurance companies may not approve, leading to diagnoses that justify shorter-term interventions. The lack of standardized assessment tools for BPD contributes to diagnostic inconsistency. While structured interviews exist, they're not universally used in clinical practice. Many diagnoses are made based on clinical impression rather than systematic assessment, introducing subjectivity and potential bias into the diagnostic process. Emergency room presentations often result in misdiagnosis. Individuals with BPD frequently present to emergency services during crises, typically exhibiting acute symptoms like suicidal ideation, self-harm, or severe anxiety. Emergency room staff, focused on immediate safety concerns, might assign crisis-related diagnoses without considering the broader personality disorder context. The tendency for individuals with BPD to have chaotic life circumstances can overshadow the underlying condition. Housing instability, relationship conflicts, legal problems, and financial difficulties might be seen as the primary issues, with mental health symptoms attributed to these external stressors rather than an underlying personality disorder. Self-diagnosis and internet research have created new challenges. Many individuals research their symptoms online and arrive at therapy with strong opinions about their diagnosis. While self-advocacy is important, it can sometimes bias the diagnostic process, either pushing clinicians toward or away from certain diagnoses based on patient expectations. The overlap between BPD and other personality disorders creates diagnostic confusion. Traits from narcissistic, histrionic, or antisocial personality disorders might be present alongside BPD features, leading to uncertainty about the primary diagnosis. The dimensional nature of personality pathology means that clear-cut diagnoses aren't always possible. Substance abuse often masks underlying BPD symptoms. Individuals might use drugs or alcohol to self-medicate emotional pain, creating a secondary problem that becomes the focus of treatment. Addiction professionals might miss the personality disorder entirely, attributing all symptoms to substance abuse. The chronic nature of BPD means that individuals often have extensive treatment histories by the time they receive an accurate diagnosis. Previous treatment failures might be attributed to treatment resistance or poor motivation rather than incorrect diagnosis. This pattern can create hopelessness and treatment fatigue that further complicates the diagnostic process. Family involvement in the diagnostic process can both help and hinder accuracy. Family members might provide valuable information about long-term behavior patterns, but they might also have their own biases and interpretations of the individual's behavior. Balancing family input with individual assessment requires clinical skill and experience. The tendency for BPD symptoms to improve with age can complicate retrospective diagnosis. Older adults might no longer meet full criteria for the disorder, but their treatment history and past functioning patterns might clearly indicate BPD. Clinicians need to consider developmental factors when assessing personality disorders across the lifespan. Legal and forensic contexts create unique diagnostic challenges. Individuals involved in custody disputes, disability claims, or criminal proceedings might have motivation to minimize or exaggerate certain symptoms. Forensic clinicians must carefully assess the validity of reported symptoms while considering external motivators. The impact of medication on symptom presentation can obscure accurate diagnosis. Mood stabilizers, antipsychotics, and antidepressants might mask some BPD symptoms while leaving others unchanged. Clinicians need to understand how medications affect personality disorder symptoms to make accurate diagnostic assessments. Group therapy and peer support experiences can influence how individuals understand and report their symptoms. Exposure to others with mental health conditions might lead to symptom adoption or modification of symptom presentation. Clinicians must carefully assess which symptoms are genuine versus learned or adopted. The role of medical conditions in mimicking psychiatric symptoms cannot be overlooked. Thyroid disorders, hormonal imbalances, neurological conditions, and autoimmune disorders can all create emotional and behavioral symptoms that resemble BPD. Comprehensive medical evaluation should be part of any thorough diagnostic assessment. Social media and online communities have created new ways for individuals to understand their experiences. While these platforms can provide valuable support and education, they can also promote diagnostic ideas that might not be accurate. Clinicians must navigate the influence of online information while conducting their own thorough assessments. The economic impact of misdiagnosis extends beyond individual suffering. Inappropriate treatments waste healthcare resources and fail to provide the targeted interventions that individuals with BPD need. Accurate diagnosis leads to more effective treatment, better outcomes, and ultimately lower healthcare costs. Training programs are beginning to address these diagnostic challenges by providing more comprehensive education about personality disorders. However, changing established practice patterns takes time, and many currently practicing clinicians would benefit from additional training in BPD assessment and diagnosis. The development of new assessment tools and diagnostic criteria continues to evolve. Researchers are working on more reliable and valid methods for diagnosing personality disorders, including dimensional approaches that might better capture the complexity of these conditions. Understanding why BPD is often misdiagnosed is crucial for improving outcomes for individuals struggling with this challenging condition. Accurate diagnosis is the foundation of effective treatment, and continued education and awareness can help reduce the years of suffering that result from diagnostic delays and errors. The path forward requires commitment from mental health professionals, healthcare systems, and society as a whole to better understand and accurately identify BPD. Only through improved diagnostic accuracy can we ensure that individuals receive the specialized treatment they need to build more stable, fulfilling lives. If this message speaks to you, we'd love it if you gave this video a thumbs up, share your thoughts in the comments, and subscribe for more meaningful content. Your support helps other people discover their path to healing. Thank you for being part of this growing community.